I would like to introduce two members of the club who have joined in today. We have Khyati with us, who is a fellow member and is also a genetic counselor in Apollo in Hyderabad, and Mayuresh, who's also the founder of the club, who's studying his master's in bioinformatics in Boston University and is also a level 2 genetic counselor. And without further ado, I would like to acknowledge and thank Dr. Vinod for joining in. And just a small, humble introduction from our end to him would be, first of all, it's a great honor for me to introduce Dr. Vinod, and he is a distinguished clinician who turned into a computational biologist. Dr. Vinod Scaria has been dedicated to understanding the function, organization, and regulation of genome, particularly in relation to how genomic variations impact rare genetic disease. Um, he co-founded the Guardian Network, one of India's greatest collaboration focused on rare genetic disorders. His groundbreaking contribution extends to major genomic projects across India, Sri Lanka, and Malaysia, offering vital insights into genetic diversity. Dr. Vinod has also been pivotal in shaping the response to the COVID 19 pandemic through his work in SARS CoV 2 genetic epidemiology and vaccine breakthrough infections. In addition to his work, he has over 200 research publications. He is highly sought after speaker, having earned numerous accolades, including his CSIR Young Scientist Award and Fellowship of Royal Society of Biology. Today, we are privileged to hear from a leader in genomics and a true visionary in healthcare innovation. Thank you so much for accepting the invitation and joining us today, sir. And I would like to commence with the precision medicines in genomic session today. And we are all ears for you with the presentation.
Thank you very much for the invitation, and it's a pleasure to be being in this session. And wonderful to know that you have been conducting a session for me. Always a pleasure.
Sorry to interrupt, sir. It seems like there's
Can you
some,
hear me?
yeah, there's some glitch from your end, maybe due to internet connectivity.
Can you hear me now?
Yep, we can hear you clearly, sir. Thank you.
Yeah, sure. Sorry for the last minute interruptions. Thank you very much for inviting me here. It's a pleasure to know about the Journal Club and that it has discovered many episodes now. And it's my pleasure and honor to be part of this session. Thank you very much for inviting me.
The pleasure is completely ours, sir.
Shall I start with my presentation?
Absolutely, sir. Thank you.
Hope my slides are visible.
Yes, sir, they're visible. Thank you.
Sure. Thank you very much. Right. So over the next 20-25 odd minutes, I hope to give a brief overview about our work in personal genomics and how we have taken from a personal genome to populations in terms of implementing precision medicine and back to individuals, because at the end of the day, it is individuals who would benefit from the personal genomes of themselves, and apart from that, other individuals in the society who would also benefit from your personal genomes. And before I start, I think I need to give a brief background on why we started and why we did what we did. Now, this is a slide from way back in 2008, and what you see here is essentially the admixture plot of the world. This is from the Human Genome Diversity Project, which was using a few markers across the genome to assess how diverse or how admixed are populations across the world. Now, what you see here is populations across the world in terms of how admixed or more or less admixed they are. And what you would see is that populations across the Middle East and Central and Southeast Asia are heavily admixed. And today, this population is approximately a third of the global humanity. And the bottom panel that you see is the genomes or whole genome sequences, which were available in 2008. And there were 6 that were available. This includes the reference genome, the Chinese, Japanese, and the Korean genomes, and the Craig Venter and the Jim Watson genomes. And what you see here is very stark, is that the most admixed populations across the world, or a third to almost half of humanity across the world, did not have much of a representation in terms of whole genome sequences. Now, this is what we wanted to change because of the inequity in the distribution of genomes and the non-availability of genomes which encompass large admixed populations across the world. So in 2009, with my colleague Dr. Sridhar Shivasubbu, we put together one of the first genomes from India, and this was announced in the end of December 2009. And to that effect, an announcement was made in the parliament. And it's not just enough to do one sequence, because one sequence is only going to prove you can do it. But the idea was to essentially cover the genetic diversity of the most admixed populations across the world, ranging from Middle East to Central and Southeast Asia. And through many years and multiple different collaborative projects, we ventured out into sequencing and understanding the genetic diversity of not just the Indian population, but also the Middle East and Central and Southeast population. Thanks to fantastic collaborators from across the region, we'll also be fortunate to be part of the Sri Lankan, the Malaysian, and the Middle East genome programs in terms of providing very useful insights into the genome sequences and analysis of genome sequences. Now, I'm not really sure whether you appreciate the fact that India is a very large country. To put numbers, India is approximately 1.4 billion people, roughly almost a sixth of global humanity lives in India. And of course, our neighbor also encompasses another a sixth of the global humanity. But unlike many other countries across the world, we have very diverse genetic ancestries and admixed, as I sort of stated before. We are one of the most admixed populations across the world, and therefore a hot point for genetic diversity. Now, unlike many other large countries which are quite less admixed or homogeneous, our population is stratified. Stratified necessarily means that these are segmented with a bit of homogeneity in between, largely because of customs which precluded marriage outside communities. And these communities could be based on ancestry, could be based on tribal instinct, could be based on caste, could be based on religion. But nevertheless, we tend to marry within the same community, and therefore we ended up having a stratified community. And to put numbers, we would have approximately around 4,000 such stratified, defined communities across the country. And more importantly, and very different from the rest of the world, which has gone through in the last 3 to 4 centuries, multiple rounds of war and famine and displacement, India has largely been undisplaced by any of the major global events. And this would mean that we have a close-knit family structure, and many of us could trace 3 to 4 generations of our ancestry. Some of them could actually trace much longer, and everything in genetics starts with an extended pedigree. So put together, we are in an enviable position of a large population, diverse ancestries and diverse stratified populations, a close-knit family structure, which would mean that India would be a very unique proposition to understand genetic diseases at a scale that was never possible before. And given the rarity of many of these genetic conditions, in India with a 1.4 billion people would mean that even a rare genetic disorder, which is 1 in a million or in terms of prevalence, we would still have a few thousand of them. So in 2011, we started working on genetic diseases, and our foray into genetic diseases was actually because of a patient who contacted us and was very persistent about us working on the genetic condition. And this is the genetic condition that he has. His skin erupts into small bullae and breaks open, something like you would get when you have a wound or you have an infection. And this get infected, and this is quite painful. And we could, over many months interacting with the patient and extended family, put together this extended pedigree spanning 5 generations, around 28 odd affected individuals. And for this particular genetic disorder, which otherwise is an extremely rare condition called epidermolysis bullosa, this is globally the largest pedigree for this disorder, or the largest family affected for this genetic disorder. With the genetic tools that we have in place, we could, of course, diagnose this condition as epidermolysis bullosa with a keratin 5 mutation. But more importantly, this family could be counseled appropriately, because this was thought to be a curse to this family. Today, we know it is a genetic disorder, and we have a molecular evidence that this is a genetic disorder. And with the genetic disorder insight in hand, the diagnostic in hand, the family could pretty much end the diagnostic odyssey for many generations. More importantly, they could prevent the onset of the genetic disorder in the next generation by evidence-based genetic counseling and prenatal testing. Or in other words, this is also an example that you can pretty much end the diagnostic odyssey and also pretty much end the onset of a genetic disorder in the future generations, provided you have the right access to diagnostics and you have the right access to genetic counseling. So we took over many years in building this into a very large program, and which was formally funded only in 2015 with CSIR. And this program is called Guardian. It's called Genomics for Understanding Rare Diseases India Alliance Network. And over the 8 to 9 years after the funded program was sort of initiated, we have grown much big, encompassing close to around 280 odd clinical collaborators from around 70 centers across the country, taking such a project from research as a mode of education, diagnosis for thousands of patients, implementation of public health measures, and of course, providing data for the national rare disease policy. The inclusion of many rare genetic diseases in the national rare genetic disease policy, fortunately India today has one, is largely because of data that came out of this very large project, and also which uncovered hitherto extremely rare genetic disorders which are extremely prevalent in Indian populations. I'll just probably mention one more story, and this is a story of a family who petitioned the President of India permission to euthanize 6 out of their 8 children. And this came in press sometime in 2015. And since I was with the government at that point in time at the CSI Institute of Genomics Integrative Biology, this got referred to the program. And that, as you see in the photo, that's the family. The family has 8 children, except for the first and the last children who are not in the photograph. The 6 children have a progressive neurological disorder. They're perfectly normal to start with at birth. and around 3 years of age, they start losing their milestones, and you see in the clockwise direction, they eventually end up in a vegetative state as they grow older. They did not have a diagnosis, they did not have a cure, and therefore the family petitioned the government of India to euthanize their own kids. Now, this is the plight of many families. This is not probably isolated. Probably many families go through this because they don't have a diagnosis, and in many ways, they don't have hope. Now, with genomic tools, we did diagnose this family, and with the right kind of tools, you could do exome or genome sequencing, which we did for multiple members of this family, and we came to the diagnosis of MLC1 genetic mutations, which sort of confirms the diagnosis of cystic megalencephaly, on scientific terms, megalencephalic leukoencephalopathy with subcortical cyst type 1. Now, for most of the patients and families with a genetic disease, the diagnosis is probably the end of the diagnostic odyssey, and people tend to forget the rest of the family and the community. We were really curious about this family, so we went back to a door-to-door survey compassing close to around 100 odd individuals in multiple households in and around Abra. And what we found was even more remarkable. And what we found was we did find another two families with children suffering from the same genetic disorder. We found approximately 28% of individuals in the extended community carriers for this genetic mutation. And this would roughly mean that approximately 1 in around 400 to 500 children born in this community would have this extremely rare genetic disorder, which in prevalence would be 1 in a million. So in other words, what you think as extremely rare or ultra rare genetic conditions, just because of the practice of marriages within certain societies, in fact, 90% of Indian marriage is decided by either caste or religion. This would mean that many communities would have such rare or ultra rare genetic conditions at very high frequency. And given the population structure, we would be able to identify such founder events, this is a founder mutation, and be able to provide them a very cost-effective, affordable, and accessible diagnostic along with genetic counseling, which could provide them an opportunity to prevent the onset of the disease in the extended community. Now, this becomes the second founder mutation for this disease. In fact, both founder mutations for this disorder, MLC1, was discovered in India. The first in the Bansal Agarwal community, called the Wandernack mutation, and the second in the Nalband community, also called the Nalband mutation. So from 2016, the first case referral, through the diagnosis, through the publication, we today have a diagnostic in the market, which is in the menu of many diagnostic labs, including Dr. Lal Path Labs, which would mean that community members could access early, affordable, accessible genetic testing, and clubbed with genetic counseling, they can provide opportunity to prevent this disease in the next generation. Now, that opens up a very interesting question on what is really prevalent, because this becomes a very pertinent question in practically every meeting on rare genetic disorder. There are disorders which are prevalent, there are disorders which are not prevalent, and in most cases, we refer to the international prevalence of genetic disorders because we don't have data from India on the prevalence of many such conditions. Now, how do we really estimate prevalence? And one way to estimate prevalence is to essentially look at a cohort of individuals and do a door-to-door survey to estimate what genetic disorders you have. But that is really not practical in most situations. So in many ways, the prevalence estimates largely come from clinical centers where patients tend to go to clinicians with a genetic disorder. But you need to keep in mind that this comes with a caveat that only patients who have a severe genetic disease might end up with a healthcare institution. And on top of it, the clinician needs to accurately diagnose a condition, and then only that gets added into the prevalence estimate. In many ways, patients fall off either in their ability to approach clinical centers or in their ability to get to a diagnosis, and therefore prevalence estimates for many genetic disorders which are otherwise prevalent seems to be missing. Now, there is another alternative to do this, and the alternative to do this is to essentially sequence individuals from the population at random and ask a very simple question: if you are a carrier for a genetic mutation. And in fact, all of us are carriers for multiple genetic conditions. But in many ways, when you talk about a recessive genetic condition, a carrier status does not make you a patient. But when you marry another individual from the same community and who is also a carrier for a genetic condition, you would have a 1 in 4 probability of developing the recessive condition in your offspring. So, roughly speaking, you could take representative individuals from the population. You could look for carrier status of genetic diseases in those individuals and ask a very simple question: depending upon the prevalence estimate of the carrier status in the population, can you predict the incidence or prevalence of a genetic disorder in the population? In fact, people have done this multiple times in multiple different populations. And this provides an opportunity, at least in India, given the specific situation of healthcare access and ability to diagnose, to be able to understand such genetic conditions. So in 2019, we were fortunate to be one of the labs which pioneered the population scale genomic initiative in India with 1,000 odd genomes. Of course, 1,000 odd genomes in India is a very, very small number because this would roughly represent approximately 1 in around 1,400 odd individuals. But nevertheless, the idea is 1,000 odd individuals from cosmopolitan populations would provide a very useful insight into what is really prevalent in the population in terms of genetic diseases which are either underdiagnosed or undiagnosed. And if they are underdiagnosed or undiagnosed, then we could enable clinicians with the right kind of diagnostic tools to be able to diagnose them and treat them if possible. I'll probably give 1 or 2 examples on this. And I'm sure as students of genetics, you would probably not have even heard about this genetic condition. And this is a genetic condition called familial hypercholesterolemia. The prevalence of genetic familial hypercholesterolemia, which is an autosomal dominant genetic condition, from the population scale data is approximately 1 in 150. And this genetic condition results in elevated LDL cholesterol, or which essentially predisposes them to early cardiac events. And there is a prevention modality available, which is to put them on statins. So early diagnosis and early treatment of this genetic condition, autosomal dominant, so that therefore 50% of next relatives would be affected, would provide you an opportunity to save yourself from early cardiac events. Now, given this large prevalence of familial hypercholesterolemia in the population, we also could go back and ask this question: could we use genomic data to also estimate the prevalence of the adverse event of toxicity due to statins? Statins are very notorious to have adverse events, and one of the most prevalent adverse event is statin-induced myopathy, which requires dosage modification or withdrawal of the drug in some cases. And what we estimate is that approximately a third of Indians would require a dosage modification for at least one of the statins, and 10% of individuals would require a dosage or reduced dosage for almost all statins that are there in the market. So, in other words, you can not just identify the prevalence of a prevalent genetic condition, but also provide insights into how to go about treating the genetic condition given the pharmacogenomic landscape in the population. This is another example of primary immunodeficiency disorders. Now, primary immunodeficiency disorders necessarily means that these are individuals who have a defect in the immune system, and that would necessarily mean that they would either succumb to infections or would have a hyperinflammatory state, as in the case of autoinflammatory conditions. Now, when children do not have an immune system, they get infected, they go into sepsis, and they die. And therefore, diagnosing primary immunodeficiency disorders are almost an impossibility, because children dying out of infection is something that is very common and very prevalent in the healthcare institutions. Now, given the prevalence of the genetic condition from the population scale data, we could go back and create a prospective cohort in one of the centers. This is the Calicut Medical College in Kerala. And over 3 to 4 years, we have created an enormous large number of diagnoses of patients with primary immunodeficiency disorder. And we roughly estimate the prevalence is approximately, or rather incidence is approximately 1 in around 10,000 live births. Now, early diagnosis would mean that these children could access therapy, and the treatment for at least some of them are available, which is immunoglobulins. And there is a curative therapy, which is a hematopoietic stem cell transplant, or roughly what we call as a bone marrow transplant. Now, more importantly, of course, there are much fewer number of people who could access this because of issues with early diagnosis, but a far more larger number of individuals could access genetic counseling and, more importantly, access to genetic diagnostics, so that they can prevent the recurrence of this disease in the next offspring. With support from the government and also from NGOs, we have created a clinical core which can look at such patients with primary immunodeficiency disorders. And the center also offers diagnosis at the center using molecular tools, including genetic tools, for patients who are suspected to have primary immunodeficiency disorders. The other kind of genetic disorders we come across is intellectual disability, and that is very, very prevalent, at least in the population. Now we know from the genetic insights that at least a subset of them are actually not just treatable, in some cases, they are curable. So the primary question that you would ask is, these are therefore the treatable conditions which would be in the list for disorders that need to be screened at newborn, because the early diagnosis you can make for many of these conditions would necessarily mean that you could put those children on early treatment, and therefore those children can grow into normal members of the society. But to understand what needs to be included in the newborn screening programs, you could go back to the genomic data and ask very simple questions about what is really prevalent and what genetic variants are prevalent, or what disease are they prevalent, and probably put together a prevalence estimate for many of these genetic disorders. And in many ways, what we estimate is many treatable genetic conditions, like, for example, Wilson's disease, phenylketonuria, at least in northern India, biotinidase deficiency, are all very prevalent in the population compared to the global prevalence estimate. And for example, Wilson's disease is around 76 times more common when compared to the global frequency. Now, that would provide very useful insights into what needs to be added into the newborn screening program across different parts or different states. Now, of course, as we speak here about genetic disorders, before I close, I need to also say that we are in the verge of a convergence in our ability to diagnose genetic disorders. Today, we use a variety of tests for a variety of genetic conditions, and the test is largely dependent upon what you really suspect in that particular genetic condition. So when you talk about chromosomal abnormalities, syndromic presentations, you would go and do a karyotyping or a FISH. When you suspect a chromosomal deletion, you would do an array CGH or an MLPA, a chromosomal microarray. Then there are repeat expansion disorders, like, for example, spinocerebellar ataxia, where you do a repeat PCR. In some cases, like sickle cell anemia or thalassemia, you do a PCR sequencing. Some genetic disorders, you do a panel testing. In some genetic disorders, you do an exome sequencing. So there are very different tests today applied on very different kinds of patients. And in some ways, multiple of these tests are applied onto one single individual, because we use a triaged approach where we test for one. If it is negative, we go for the next test, and so on and so forth. In many ways, this would mean that the patients incur an enormous amount of cost, and they lose an enormous amount of time to arrive at a diagnosis. Now, what I'm why I'm trying to say this here is because today we have a tool to be able to diagnose every genetic condition and every type of genetic mutation using a single assay, and that is whole genome sequencing. And the whole genome sequencing is faster than any one of these tests individually, and more importantly, is becoming cheaper, affordable, and accessible. And therefore, in the future, we sort of tend to believe that whole genome sequencing will replace all of these tests and can provide much better insights on the patient's genetic makeup with a single test which is fast, affordable, and accessible. And in fact, there is data across the world on why this is an important thing to do, because people have suggested that a whole genome sequencing provides much better diagnostic positivity compared to the standard of care. In fact, some studies have even estimated whole genome sequencing diagnosis approximately 40 to 50% of the cases. And this becomes very important in the context that the cost of sequencing is dropping quite very rapidly. And as you see here, this is the cost of sequencing, and this is in the log order. This is not even a linear order, this is in a log order. And it would necessarily mean that in a few years' time, whole genome sequencing would be as affordable as any other genetic test, and therefore could replace almost all of these genetic tests with a single, fast, efficient, affordable, and accessible approach. The other thing that you need to keep in mind is that when we talk about the clinical spectrum of diseases, not just genetic diseases, but diseases in total, we need to use genomics after the patient has come to the clinic. And when the patient comes to the clinic, that necessarily means that the patient is ill or has or disability and therefore has come to the clinic. They have completely lost the opportunity of risk assessment and screening of individuals who are pre-symptomatic or are apparently normal, like you and me. And therefore, we need to sort of change the paradigm on how we apply genomics. Today, we apply genomics when a patient comes to the clinician makes a rough diagnosis and sort of adds a set of diagnostics to the compendium. Genetic diagnosis is today one of the many diagnostic modalities applied on a particular patient to be able to arrive at a diagnosis. In other words, the patient has already developed this, and we are fortunate enough to go to the right clinician who can make a diagnosis and offer genetic testing. But in many cases, especially treatable genetic disorders, there are around 200 today, the opportunity is lost because you have already become a patient. So you need to change this paradigm or our ability to identify patients before they develop their signs and symptoms. And genomic sequencing today can offer that. In other words, with genome sequence, today you can look for genetic variants, high level of evidence, you can access genetic counseling, and clinical care be able to prevent the onset of disease, delay the onset of the disease, and therefore we could continue living as normal, healthy individuals. And of course, newborn screening is one of these modalities, but of course, there are many more things that can be done. And available and accessible in India, and this is where my colleagues at Kanpur together is a preemptive whole genome sequencing, which can provide risk assessment for hereditary cancer syndromes, which today is the most prevalent genetic disorder in the community. Approximately 2-3% individuals in the community do have a germline risk. Management in pharmacogenomics.
So,
There are 305 clinical.
your audio,
Can you hear me?
yeah, the audio is just lagging for us.
Oh, sure.
Yeah.
Pharmacogenomics, which can sort of preemptively test yourself for adverse events that can develop because of drugs. And of course, this comes genetic counseling so that you can make your decisions for your life. And I think before I close, is to summarize, genome sequencing is becoming affordable routine implementation. For individuals, it can enable a disease diagnosis and risk assessment, and put together for populations can estimate population scale frequencies of genetic disorders. Genetic disorders are extremely prevalent, including individuals who apparently are common to me, might have genetic risk for conditions, and most importantly for cancer. Genomes are there for everyone because every single individual would benefit from the whole genome sequencing. And more importantly, your genome is constant from the day you're born to the day you're dead. So in summary, if you sequence newborns at birth, would be probably the most cost-effective investment for healthcare. Thank you very much, and I can take questions.
Good evening, everybody. Thank you so much, sir, for that extremely interesting and a great compilation of the session that you have taken us through. The audience members, if you have any questions, please feel comfortable to unmute yourself or put it in the chat box and we will take it up. I would really like to pick on your last point, sir. I do know that there are some projects going on throughout the world. There's some project in China and some in the US, which is called the BabySeq project, wherein they're trying to do genomic sequencing as a newborn screening technique for newborns. And you seem quite inclined towards that. And it's quite interesting to learn because I think India still has a long way to go. There are many benefits, but also many challenges for the same. What is your perspective on how India can take this approach? Sorry, sir, I think you are on mute. So sorry to interrupt.
This is so expensive and therefore not for India. What you should imagine and we should think is that there is almost 2% of Indians are as rich as Americans, right? And if they could afford sequencing, so could people in India. The second point that I'm trying to also say is that there are a lot of people who today waste money on apparently useful things which are not very useful. And one of the examples is stem cell banking or cord cell banking, right? Which apparently has no clinical utility, but nonetheless is expensive. But hundreds of people who are doing that, right? Today, a whole genome sequencing is probably cheaper than banking your cord cells. And therefore, I think we should have a frame shift in a mind that Indians can do this, provided we provide the right information to patients in the community. Right? And the right information we need to provide is that the clinical utility of stem cell banking is much lower than the clinical utility today for a whole genome sequencing. And the utility and the evidence of whole genome sequencing is exploding as we talk in the years to come. Genome sequence is going to explode, but the utility of the genome sequencing is going to explode. And therefore, in many ways, newborn screening for people who can afford, and I think that point, who can afford, is something we should make a mainstay. While we do this at a population scale, we will be able to identify genetic disorders which are prevalent, and a much cheaper, affordable newborn screening program can be implemented for the 95 or 98% of individuals who might not be able to afford a whole genome sequence. So it would therefore become a balance in most ways. Not to say that only the rich people can do whole genome sequencing and access the technology, but more importantly, by rich people accessing the technology, you can make poorer people access technology in a more affordable and accessible way. So therefore, I think for individuals who can afford, not just for newborn screening, but even for adults who can afford whole genome sequencing, becomes a very useful tool.
Thank you so much for that answer, sir. It's quite a refreshing perspective on this because I have mostly come across people who are not much in favor of a broad spectrum testing, like a genome sequencing, as opposed to more targeted approaches. So, this was a very refreshing take on the same topic. However, sir, do you think that there is, or like India is not prepared for the sort of technological burden this will bring if we start doing genome sequencing for newborns or as a technique, as you mentioned?
No, I don't think we are technically challenged to be offering whole genome sequencing because we do have the wherewithal, the resources, and the capacity to be able to offer whole genome sequencing. The only thing that is preventing us from giving whole genome sequencing or people accessing whole genome sequencing is largely a mindset. This is not very useful for patients. This is very excellent for patients. We need to keep in mind that for many patients, um, being offered whole genome sequencing would be a game changing. They were never aware. For example, screening for hereditary. Like I come with families have familial cancer, multiple generations of individuals who have died of breast, prostate, pancreatic cancer, but they never were advised to be able to do germline screening. And now they understand that they do germline screening and there are protocols for diagnostic treatment conditions. They could live a perfectly normal life, or they could have a planned normal life. And something to put across the community at large.
Right. Very interesting, sir. Now, well, to just summarize the entire session, thank you for highlighting how this country is approaching personal genomics, especially with regard to its genetic diversity. And with the examples that you have given, I think we've understood how the clinical outcomes have been integrated with the support of personalized medicine in such a diverse population, especially with the Guardian project. And we will definitely check more about that and how we can contribute to the same. Um, and again, if the audience has any questions, you can unmute or put it in the chat. But this was a very interesting session. We had a lot to learn from you, sir. Thank you so much for sharing your time with us. And this is quite inspiring because as we were studying about you and the work that you have done as well, I think some of us are parts of the group that you lead, like Genomic Insights and things like that. So even on a daily basis, we're learning a lot from you. Uh, and you might not know about it, but there's a lot to take home. So thank you so much for that, sir. Um,
Sure, thank you very much. And as you rightly said, we do have a WhatsApp group called Genomic Counselors, and the name rightly imply what it means. It is not for genetics anymore because now we have tools to look at the whole genome in totality. And this is clearly going to be the mainstay for genetic testing. And genomic testing is not just genetic testing, but actually beyond it. And therefore, we need to have a much broader perspective of what genomics can do beyond just genetic disorders. And second, more important point that I want to make is that we are in the most exciting period of time, and probably everybody in this session who is listening to would have the genome sequencing and as part of the investigation in our own lifetimes. And probably 30 to 40% of us would have a CT scan or an MRI in our lines, and that pretty much would be the percentage of people who would access whole genome sequencing in their lifetimes. The cost of whole genome sequencing or genetic testing, genomic testing has pretty dwindled. Today, you can have a germline cancer screen for approximately the price of a CT scan. You can have a whole genome sequencing at approximately the price of a PET scan. Right? And this is very, very rapidly. And as genetic counselors, I think you might also want to sequence yourself, understand, and also use this data to benefit your own healthcare and also have insights so you could advise your patients accordingly. Right? And unless you experience that yourself, think you've actually missed out an opportunity to impact your own patients at scale. Thank you very much for organizing this session.
Thank you so much, sir. That was a really good take home message for all of us, even for the genetic counselors out there to learn about their healthcare and apply it in their practice. And thank you so much for this insightful presentation and joining us on a festive event of Ganesh Chaturthi. I wish all of you who have joined and you as well, sir, a happy Ganesh Chaturthi. Thank you all.
Thank you.
Bye, sir. Enjoy your Ganesh Chaturthi. Thank you so much.
Thank you, sir.